The title of my talk today is Focal Brachytherapy in the Treatment of Prostate Cancer as part of the Southwest Prostate Cancer Symposium. What is the rationale for doing focal therapy? We know that there is a small percentage of patients that may not have bilateral multifocal disease. And it's perhaps these patients that we get treated with partial gland therapy. Partial gland therapy, just by the nature that we're only treating part of the prostate, can reduce morbidity. It also leaves open future partial gland treatments. In addition, the dominant intraprostatic lesion may dictate how one treats a patient and the natural history of the disease. And with the use of MRI, our knowledge about tumor extent is changing as well as the aggressiveness and can help us in defining focal therapy. This slide talks about the comparison of MRI ultrasound fusion guided biopsy with standard ultrasound guided biopsy in the diagnosis of prostate cancer. This came out in JAMA in 2015. And the level 1 evidence showed that MRI ultrasound targeted biopsy outperforms a 12-core standard biopsy. It detects 30% more high-risk cancer, 17% less low-grade cancer. And the accuracy is 77% for MRI targeted biopsies versus 53% for standard biopsies. This slide discusses image-guided focal therapy for MRI visible prostate cancer, defining a three-dimensional treatment margin, and it's based on MRI imaging with correlations to histopathologic co-registration. So this used a 3T MRI and analyzed 33 patients. So what it found was that the MRI can underestimate lesions by volumes up to 32%. So what this tells us that if we're going to define a lesion by MRI, we need to add margin to it. And you can see from the slide on the right that the MRI lesion in purple, but the histologic lesion is in pink. So I think it's important, especially if you're using brachytherapy, when we think about where the lesion is, that we're going to have to treat it with a margin which obviously will need to be determined based on the type of brachytherapy implant and the amount of the prostate that you're treating. The topic of this paper was correlation of the MRI imaging tumor volume with histopathology. This was a paper of 135 patients who had intratumor volume, the median value of 1.9 cc's, and the MRI area under the curve in terms of comparison with the actual histopathology was 0.94. And then MRI overestimated the size by 7%, but overall gave a good estimation of the intratumor volume. You can see on the bottom slide A, you have your tumor on MRI, and B is the histopathologic correlation to that. The title of this study is Volumetry of the Dominant Intraprostatic Tumor Lesion, Intrasequence and Intra-Observer Differences on Multiparametric MRI. So the figures on the bottom are comparison of intersequence volumes with histology. C shows tumor outline drawn on 3 separate occasions by observer 1 and overlaid. And so you can see based on the different sequences, you're getting different images. They're quite similar, but there is some differences. Again, I think this supports the fact that whatever imaging sequence you're going to use, you're going to need to build in a margin. And again, you may get to the point where the lesion's so big that it doesn't really make sense with a margin to do focal therapy. But it's important to understand, depending on the image, that there may be different volumes. So the main question comes when you're using any kind of focal therapy is how does one monitor disease progression? Because we know we are not treating the entire prostate. We have prostate that is left untreated and is making PSA. So the question is, what should the PSA be after focal therapy? We don't really know that, but these are important things that we need to be focusing on in the future. What is the role of doing post-treatment biopsy both in the treated area as well as outside? Should additional therapy be implemented to the maybe untreated area? And what are the appropriate endpoints for clinical trials? Here's a list of some of the available treatments to do focal therapy. There's high-intensity focal ultrasound or HIFU, laser ablation, partial prostatectomy, cryotherapy, photodynamic therapy, radiofrequency ablation, brachytherapy, and IMRT/SBRT. In terms of patient selection, every particular study uses its own selection criteria, but in general, we're dealing with unilateral disease. Most studies require that there's an MRI detectable lesion that we can plan on. For most of the studies, Gleason scores of 6 and 7 are used, but usually exclude Gleason scores of 8 to 10. And PSAs typically have to be less than or equal to 10. The title of this slide is Prostate Cancer Laterality as a Rationale of Focal Ablative Therapy for the Treatment of Clinically Localized Prostate Cancer. This is a study comprised of 1,184 consecutive men with pathologic organ-confined disease who underwent a radical prostatectomy, either retropubic, perineal, or robotic at Duke University Medical Center. And what this found out of these 1,100 patients, that unilateral tumors were found in 227 or 19% of these patients. So keep in mind, this is a relatively rare occurrence in terms of detecting which patients that it's a highly select group of patients that truly do have unilateral disease. And this just shows the pathologic Gleason score distribution among unilateral tumors from that study. And you can see that about 60% of the cancers have Gleason scores less than 7. About 30% of Gleason scores of 7, and certainly about 5%, a much smaller percentage, have Gleason scores of 8 to 10. Figure 2 shows the percentage of tumor involvement, the PTI distribution, among unilateral and bilateral tumors. So you can see as the amount of tumor increases, you're more likely to have bilateral tumor involvement, and the smaller the amount of tissue, the more likely it's going to be unilateral disease. So you can see if you have greater than 15% of the prostate involved by cancer, most of those patients with the large white bar have bilateral disease. This is a review article entitled New and Established Technology in Focal Ablation of the Prostate, a systematic review. And this figure that I show here just gives you a schematic representation of the types of focal therapy that are currently available. A is meant to represent a high intensity focused ultrasound. B is cryotherapy. C is photodynamic therapy. D is laser induced interstitial thermotherapy. E, brachytherapy. F, irreversible electroporation. And C, radiofrequency ablation. There were 37 articles reporting on about 3,000 patients undergoing focal therapy. 13 reported on HIFU, 11 on cryotherapy, 3 on photodynamic therapy, 4 on laser interstitial therapy, 2 on brachytherapy, and 3 on irreversible electroporation, and 1 on radiofrequency. So brachytherapy is a relative rare thing, and I'll show you in the next couple of ongoing slides. This is just a list of some ongoing clinical trials, and you can see the first 5 of them are HIFU. Then there's some other non-radiation therapy type of focal therapies. The bottom where the blue arrow is represents the first trial involving brachytherapy. And the continuation of this table again shows that approximately right now there are 4 ongoing NCI designated clinical trials involving brachytherapy and focal therapy, and the rest are non-radiation options. So this is a paper from Radiotherapy and Oncology, and it's the feasibility of treating the dominant intraprostatic lesion with a boost that can be used can be delivered either with photon, proton, or brachytherapy. And this kind of just shows you in figure 1 the different types of techniques that you can be used with. The whole prostate is treated with the primary modality. With IMRT, we know intensity modulated radiation, we can create higher dose regions where we're delivering higher doses per fraction into very smaller areas. And I certainly do this when I'm treating with IMRT alone. I mean, I know where the tumor is and give it higher doses. This certainly can also be accomplished with the second figure, which is intensity modulated proton therapy. And finally, some people are looking at a different type of paradigm where you're giving the prostate, let's say 45 gray of external beam radiation therapy. And then instead of giving a boost with brachytherapy to the whole gland, just treating the dominant intraprostatic lesion with the boost in hopes of reducing morbidity. So this is the report of a consensus meeting on focal low-dose brachytherapy for prostate cancer headed by Stephen Langley from the UK. And this table is the consensus finding on the patient selection for focal therapy. And these are patients that have life expectancies greater than 10 years, PSA less than or equal to 15, and MRI, multiparametric MRI that is performed prior to biopsy. Also, it recommends bilateral template-guided prostate mapping biopsies with 5 mm sampling frame. It calls for unilateral disease, lesion size less than 0.5 ml, with or without clinically insignificant disease on the contralateral side, Gleason scores of 6 to 7, stage less than or equal to T2B, and prostate size less than or equal to 60. And this is a diagram from that paper, just kind of demonstrating the different types of partial gland therapy that can be given. You can see on the top, you have what we'll call ultrafocal therapy, which is really the lesion with a margin. They call focal therapy, which might be a hemigland or a quadrant, and focus therapy, similar to the gland. You can see you can create any types of dose distributions using treatment planning. So I really think brachytherapy is really quite uniquely suited for delivering focal therapy. You could decide what type of focal therapy you're going to give. And that could be, again, treating a quarter of the gland, half the gland, or just treating the lesion with a margin. And you can decide that based on where the lesion is, the size of the lesion, and its location to other normal tissues. This is the consensus finding on focal brachytherapy and a study protocol. I'm not going to go through all the various arrows, but you can see if you look at that after the biopsy and the MRI, they recommend a 6-week interval between biopsy and MRI. Depending on what's found, one could determine what type of partial gland or focal therapy should be done with brachytherapy. So in terms of focal low dose rate brachytherapy, that's using permanent radioactive seeds, which is a technique that I employ. We have to first determine what the target volume is. Again, we use MRI for that. I do believe in again, creating a margin around that, depending on where its location is. That margin could be a half a cm, 1 cm, 1.5 cm. Again, depends on what you want to do. If you want to treat a quarter of the gland, you're going to have larger margins. Certainly, if you're just treating half the gland, you're going to do that. But remember, as you treat more and more prostate, you're going to treat more and more normal tissue, and you're going to bump up your treatment-related side effects. So the more focused, the less side effects. And again, techniques that can use traditionally would be a pre-plan, which I usually recommend doing, especially because you are dealing with an MRI image, and it's very good to have at least some type of plan of where you're going to put the needles. But we do also use real-time ultrasound to make sure that our needles are actually in the place we want it to be, and not, in the rectum or in the urethra, despite what the plan might show. So this is just an example of a focal therapy case where there was a lesion that existed in the patient's base on his right side. And it was a very small lesion and detected only by MRI. The patient underwent repeat biopsies of that lesion, it was Gleason 6, and repeat biopsies of the other areas of the prostate that did not have the lesion, which did not reveal any cancer. So we designed a plan using iodine 125 to deliver the yellow line of 160 gray to this. And we were very careful. We ended up using, as you can see, 8 needles. We were able to get the dose we wanted to that and avoid treating the urethra and avoid treating the rectum. And this patient did well with virtually no side effects. This is the post-implant dosimetry of that patient. And you can see those seeds that correspond quite nicely to where the needles were placed. You can see they're not near the rectum. They spare the urethra dose, and they do encompass the tumor volume. So I want to go over some of the few publications on focal brachytherapy. Again, this is from Stephen Langley's group. It's dosimetric modeling for focal low dose rate prostate brachytherapy, more of a physics contribution. And figure 1 is an example of a focal lesion delineated on a T2 weighted image and a diffuse weighted MRI apparent diffusion coefficient map of the prostate. You can see the lesions match up quite nicely. And this paper just kind of talks about what I've been talking about a lot, which is the different types of treatments Figure A is a whole gland brachytherapy implant. Figure B, as you can see, is a hemigland treatment plan. The isodose lines, again, the prescription dose is 145 gray of iodine 125. And figure C just shows a focal therapy. So the lesion, as you can see in blue, plus a margin. As you can see here, the margin to the tumor gets smaller and smaller as you go from whole gland to focal therapy. This is a group from Paris discussing focal brachytherapy for selected low-risk patients, a pilot study. This was published in Brachytherapy in 2013. There are 21 patients who underwent focal brachytherapy between February 2010 and March 2012. It only represented, as I mentioned earlier, a very small percentage, almost 4% of the cases treated by that group. Patient selection was based on prostate biopsies and high-resolution MRI. And this is basically showing you what their typical focal therapy, which is the lesion plus a margin, looks like. Very similar. This is rendered on the Veriseed computer, one showing the seed position, the other the 145 gray for iodine 125 isodose line. And as part of this trial, they did systemic histologic follow-up with biopsies, and they were performed from 12 to 24 months after focal treatment. 6 patients overall underwent controlled biopsies, and those were the months 14, 18, 19, 24, and 27 months. And 1 patient refused to be biopsied. In the 5 patients, the biopsy, which were 10 to 12 biopsy cores, were all negative. In a single patient, a biopsy performed at 2 years, which is less than 1 millimeter, was found in the right base, while the focal brachytherapy was targeted in the left base. So this study demonstrates that in the area actually treated, it was very good in eradicating the tumor, and a new cancer did, come up in 1 out of the 6 patients that were biopsied. This is the most recent paper from the Langley group, looking at hemiablative low dose rate prostate brachytherapy for unilateral localized prostate cancer. They had an N of 31, and they compared it to, so 30 patients got hemigland irradiation, again, a form of focal brachytherapy, and 362 were controls from their series. And they compared treatment-related toxicity and disease control 24 months post-implant. So these are slides, these are the most interesting slides, I think. If you can focus on figure 2 on the left, and specifically look at column B. And what this column represents is difference in morbidity scores, changes. So the changes at different time points from baseline. And I think that's always more useful than looking at absolute values, because if you start out with a lot of urinary symptoms, at various time points of follow-up, you're still going to have high scores. So it's very difficult to discern differences in treatment plans in patients that may already have very high scores. So it's more important to look at the change. So if we look at the top, which is IPSS, urinary symptom score, you can see that the green, which represents whole gland, versus the kind of brick orange, which is the hemigland, at all the various time points, 3, 6, 12, 18, and 24, have higher urinary symptom scores. And while at 24 months, the hemigland have returned to their baseline, the whole gland has not, and these are significant differences between the green line and the orange line. The next slide are quality of life indicators. The same thing, you can see, worse quality of life scores in the whole gland versus the hemigland, and a return to normal by 12 months in this quality of life indicator with a hemigland. The quality of life B, also, you can see the difference between the green line, the whole gland, and the hemigland, where you have much lower scores in treating the hemigland, which makes sense because you're only treating half the prostate. And finally, the IEFF, which is a measure of erectile function, that you can see the scores for the hemigland are significantly higher, 6, 12, and 18 months and 24 months compared to the whole gland, which again makes sense. You're radiating only perhaps one neurovascular bundle to a degree, while the whole gland is radiating both neurovascular bundles. So that makes a lot of sense. And figure 3 is the PSA kinetics. You can see on the right. And again, you can see higher PSA levels in the hemigland at 3, 6, 12, 18, and 24 months compared to the whole gland. Again, this is very common sense. You're radiating the whole gland, you're more likely to get more total ablation, at least during this early time frame, and your PSA levels are going to be lower than the hemigland, where half the prostate is not even treated. And so from that particular study, they also did biopsies at 24 months. They had 26 patients. 5 patients were positive in the treated side. 2 patients were positive in the untreated side. So in this particular case, perhaps the dose they give was not as high as we would like, because our experience, certainly just doing biopsies after whole gland treatment, would reveal, in general, a lower positive biopsy rate. But what's interesting in the hemigland patients, there were no biochemical failures. So it is possible that some of these positive patients who were called positive in their institution would turn out to be negative in subsequent biopsies.